Greetings. Let us talk about ascites. How do you diagnose ascites on exam? And also some principles about fluid dynamics that result in ascites. I want to thank many who support this program, and please take a couple of minutes to review this notice. So, when you see somebody in your clinic with a distended abdomen or complain that their abdomen is getting progressively bigger and distended, you should think about fluid or ascites, which is one of the common causes for distended abdomen. Flatus, when somebody has increased gas production, either because of small intestinal backlog growth, or flatus is not going down because of an obstruction to the bowel. Fat, probably the most common cause given the increased prevalence of obesity. Feces in somebody who's constipated, and in a young woman, pregnancy and fetus. So, when I was a medical student, and I'm sure even now, people talk about 5 F's for distended abdomen: fluid, flatus, fat, feces, and fetus. So, when you go to the bedside and you have somebody lying down with a distended abdomen, uh, stand at the bedside and watch the abdomen. Yeah, not the umbilicus and the top portion of the abdomen, but look at the flanks. If they are bulging, you should think, is there ascites? And if they have an additional umbilical hernia with a bulging flanks, then you should think about possibility of ascites. And as you gently palpate and you go to the flanks and you percuss, and if there is dullness to the percussion that has extended from the flanks slightly higher up, that is another sign of ascites, especially if the dullness to percussion also shifts, otherwise known as shifting dullness. So, how do you go about demonstrating shifting dullness? So, you percuss on the flanks. Normally, flanks are dull, but if the dullness extends up to a higher level, then you ask the patient to turn from supine to either right lateral or left lateral position and percuss again. And if the dullness resolves and becomes tympanic, you know that the bowel loops floated up and fluid has drained to the other side, resulting in shifting dullness. And if the abdomen is quite tense, you can put one hand on one side of the flank, on the, say for example, on the right side, and tap on the left side, elicit a thrill that you can feel with the other hand, otherwise known as fluid thrill. So these are all the signs of fluid in the abdomen, and uh, you can elicit these signs when there is moderate amount of fluid or large amounts of fluid. Mild ascites may not be clinically detected and requires the help of an ultrasound to check for fluid in the gutters. So, fluid accumulation. Let us learn about the dynamics of fluid exchange in the capillary bed that results in the fluid in the interstitium, and what are the two main forces. You have a capillary lined by endothelium, and you have slits in between the endothelium. that allows fluid to escape out, and the driving force is known as the hydrostatic pressure that allows the fluid to go into the interstitium. And that happens on the arterial side. And as the fluid accumulates in the interstitium, the blood becomes more concentrated. The oncotic pressure on the venous side of the capillary increases, and it tends to draw the fluid because of the oncotic pressure. So these pressure changes result in fluid dynamics, especially extravasation of fluid. When there is portal hypertension with increased hydrostatic pressure that drives the fluid out into the interstitium, and if there is too much of fluid going out and the lymphatics cannot drain it, then you accumulate fluid. In the peritoneal cavity, it results in ascites. In the pleural cavity, the pleural effusion, and in this subcutaneous tissue, edema. With pressure changes, most of the fluid is uh, free from heavy amounts of protein. It's just a transudate. On the other hand, when there is damage to the capillary, any form of injury or inflammation or cancer, there is capillary endothelial damage. These pores become bigger. Not only the fluid, but the protein in the capillaries extrudes out or extravasates, resulting in an exudate, and the permeability changes result in a fluid that is rich in protein. So this is important. When you have pressure changes, the fluid is relatively free from protein in the interstitium. And if there is permeability changes, the fluid is rich in protein. That's what is the basis when you talk about serum ascites gradient when you're looking at ascitic fluid. Pressure changes, just a fluid, not much protein. So when you calculate the serum ascites gradient, it is high because albumin in the blood and the less amount of albumin in the ascitic fluid. On the other hand, if there is permeability changes either because of tuberculosis or cancer, not only the fluid, the protein is also going out. So there is a heavy amount of protein in the ascitic fluid, heavy amount of albumin in the ascitic fluid. That results in a low serum ascites gradient. So something to keep in mind. And then we're going to use the principle that we learned to appreciate the different mechanisms for ascites, heart failure, cirrhosis, from portal hypertension with a high serum ascites gradient, and cancer and tuberculosis affecting the peritoneal cavity, resulting in a low serum ascites gradient. I want to thank these authors for this beautiful article that served as a basis for this talk. Thank you.